So I just want to thank Dr. Beth Haynes for really inviting me here. I mean, this is just a privilege. I'm excited to be here, and it's just a great opportunity to talk to you guys. I love talking to medical students. And I will say that this is not about policy, so I hope that's okay. And Arthur Brooks with his talk and Dr. Armstrong with his talk have just teed it up for me, so I'm just going to swing away. All right? So let me tell you my personal story. My parents are from India. My dad lost his dad when he was about 5 years old. So he was raised by his mom and his brother. And he studied medicine in India. And he left India to continue medicine here. And he left everything. I mean, he came here with my mom, but he left all of his family behind, his mom and all of his relatives. He and my mom were the only people that were here. Now, why did he do that? So he did it for the challenge and the prestige in terms of the practice of medicine. But most importantly, he did it to really secure a good job and raise his family. And I'm not sure that medicine was really his calling. But you know what? He's still practicing today, and his patients love him. Why? Because they feel loved by him, right? So what is love here? And I want to define it so that we have a common frame of reference, okay? So the guy that really gave me this insight, a guy named Mark Goffney, says that love is not really an emotion. It's a perception, right? It's a way of perceiving. Arthur Brooks gave a perfect illustration of that in that study that he cited, where the strangers came together, and it was just how they perceived each other, right? And then he said it's not love, but it is love. That's exactly what it is. It's a way of perceiving. It's not really an emotion. And by seeing, by love, I mean it is to see. It's to see and to be seen. So love is really, it's a verb, is how I'm using it here. It's not a noun, it's a verb. So to love is to see and to be seen. And by seeing, I mean to see not only with the eye of the senses, but with the eye of the mind and with the eye of the heart. We all just want to see and be seen. And to see others the way we would want to be seen. So my version of the golden rule is see into others the way you would have them see into you. That's the practice of love, and we can actually practice this. So what do we experience when we see each other and are seen by each other in this way? What do we experience when we love? The ancient Greeks, like Plato, called this Eros. And what they meant by Eros was the life energy, the crackle, right? The movement that you feel in your body and your heart when you practice love. It's the energy, it's the joie de vivre. When we love, we feel eros. We feel erotic, right? Now, in our modern world, what if we exiled eros too? Sex, money, power, fame. We've exiled eros to all those things. Now, all those things can be erotic, but eros encompasses them, right? Eros is in the substance of them, but eros is not them. They're subsets of eros, not the other way around. And that confusion destroys the recognition and cultivation of eros in all other aspects of life, which then takes down every other calling, right? So for my dad, my family is what makes him feel erotic. We're what makes him feel alive. We're how he feels seen. He never took personal vacations. He never had big personal toys. Medicine was just his vehicle to practice love by way of his family. It enlivens him to know that through medicine, he's provided for his family, his wife, and his 4 kids. So any hardships in medicine, he didn't really care about. He just sucked it up and did it, because that was the only way that he could fulfill his role. And really, I would say that most everybody of his generation that came from India, whether they were doctors or engineers, which is primarily most of them of his generation, I mean, that's how they moved in the world. That's how they felt alive. That's how they felt erotic, right? But me, I'm different. As a first-generation Indian American, I had more opportunities than he did here. I chose medicine like most people of my generation, right? Because my parents, my dad was doing it, and you kind of got the implication that it's a good, secure, prestigious thing to do. And it was one that rewarded them really well, my parents and our family. But I had a mid-medical school crisis, right? And you will too. My theory is that it's inevitable, all right? Mine came in the third year. I just hit the wards, and I started OB-GYN, and it was miserable. The residents crushed us. I was waking up at like 3, 4 in the morning in that labor and delivery, hearing that tachometer go off, and to this day, I can't stand that noise. And really, I mean, they were getting crushed, and they were just transferring their suffering to us. But it really started to make me question, like, what's the purpose here? Is this it? Like, this is what I'm heading toward? And I started doubting the whole thing. So my plan was I was going to finish medical school, was get my MD, and then leave medicine. I was going to become a lawyer. So I started looking into how to become a lawyer, become an MD, JD, and I realized, well, you got to take the LSAT, and then I at the time thought you had to write a bunch of essays, which, you know, I was a multiple choice guy, not an essay guy, so it's kind of ironic because I love writing now, but at the time I wanted no part of it. So I dropped that idea and I just put my chips into medicine, right? And as I went through residency and then fellowship, I felt really stimulated, even though I was very tired, right? Just the love of new learnings, camaraderie with the residents, sharing cool cases, and then going out to clubs, to bars, to movies that I didn't finish because I fell asleep on them. I mean, it made us feel alive at that time. And really, that was what Mark Goffney calls the stage one of love, right? It's the romance of it all. It's raindrops and roses, whiskers and kittens. That's what I felt at that time. And then I went into private practice as a solo gastroenterologist. And I entered the world of the business of medicine, and it was an eye-opener. Because that is not what, I don't know if they teach you any of that for you guys, but we don't get taught, I didn't get taught that when I was going through training. And this was the side of medicine that you don't really get exposed to. It's all about consults, at least it was for me as I got into private practice. It's all about consults for small things an internist would never consult you for in a training program, right? And it was about coding and big billing and regulations galore. And as a gastroenterologist, I'd sometimes be seen just as a technician who was valued for my ability to scope, not for my faculty of reason. And the hardest part early on for me was really the lack of community. I mean, in training, you have your residents, you have your attendings, you have people that you can connect with. And once you get out, especially as a solo gastroenterologist, all that went away. It was really to each his own. And I had no other gastroenterologists to share interesting patients with and really to kind of to vent to. Now, I started practice where my dad was, so it was good that my dad was around. Because what I would do is complain incessantly to him, right? What I was complaining to him about was the absurdities of the practice of medicine in the real world. The waste of time consults that amounted to little more than I'll scratch your back if you scratch mine, which happens, and will churn this healthcare wheel for all it's got. The lack of deeper thought and rigor into what labs, imaging studies, procedures, surgeries, tests that you order, really that weren't really applying to a unique patient in a unique situation with unique circumstances in a unique environment. That's not what I was experiencing when I got into the practice of gastroenterology. The cookbooking of medicine was what was really making me go insane. And the apathy of it all. I mean, I felt like I was the only one that I was actually kind of experiencing this, which I realized later on was not true. And really the wasted opportunities to influence the health behaviors of sick people that we would just patch up get them home, congratulate ourselves for a job well done, only to have them come back again, patch them up again, congratulate ourselves, and have this repeated over and over again. And the burden of practicing medicine in a climate full of regulations. Now, these absurdities would not bother my dad as much as they bothered me. See, his Eros was intact because it was driven by something different, but my Eros was not. I felt like my life force was being sucked out of me, and I was beginning to burn out. I felt like a rat that was in a cage just scurrying along on this healthcare wheel. I didn't feel like I had enough time to spend with patients, that I was meeting their needs. They had problems that no amount of EGDs, colonoscopies, surgeries, procedures that could fix. But they kept getting them because that's what the system incentivizes. And primary care doctors would keep consulting you, especially a gastroenterologist, for scoping somebody. That's kind of how I was seen as a gastroenterologist, my ability to scope. And I saw myself as something more than that. It's actually harder on me not to scope somebody than to scope them, because that's actually what the system and a primary care provider, and even a patient in many cases, expects of you. At least that was my perception. So this was frustrating me, and this was really the second stage of love. So the first stage of love is falling into love. The second stage of love is falling out. So I started getting heartburn, right? And the irony was not lost on me of a gastroenterologist getting heartburn. And the more I railed internally against this system, the more my heart burned. I then truly realized when I started getting heartburn, I had to figure out, well, how do I get beyond my heartburn? That's when I truly realized how inadequate the traditional, conventional medical system is in dealing with something like reflux. Because all the traditional medical system says is take an antacid, take a proton pump inhibitor, right? And take it indefinitely. Block acid in your stomach indefinitely. And that to me was just kind of absurd to me. So meanwhile, my philosophical and spiritual path was continuing. I'd been reading a lot. I went on a meditation retreat where you sit and practice breathing for 10 days and don't talk to anybody else. And it was really a lamppost moment in my journey. And I was really feeling into the inadequacies of what we as doctors do and the system that we practice in. You see, we've been fooled. This is my take. We've been fooled. We've been misled about what the real crisis in medicine is. Okay, we've been told it's poor access to care, it's lack of standardization, it's heterogeneity across practices, it's lack of technology in health records. Don't get me wrong, all these things are important, okay? But I don't think that's what the real crisis in medicine is. The real crisis in medicine is a crisis in love. The real crisis in medicine is a crisis in Eros. Patients aren't being seen and they want to be seen, right? Nurses aren't being seen and they want to be seen. And doctors aren't being seen and they just want to be seen. Why are the rates of divorce, burnout, and suicide significantly higher in the medical profession than almost any other profession? Because of a crisis in Eros. We're not cultivating love in medicine. We're not cultivating Eros. So what do? We try to fill that existential void in another way. Working long hours for money, having affairs, settling for secure jobs with big healthcare systems. Okay, this is all pseudo-Eros. And we ultimately find it wanting, it won't fulfill the void because we've distilled Eros down to something smaller than it actually is. We're not charged about what we do. And what the left doesn't understand is that for many of us, Obamacare isn't getting us charged about what we do. It's dumbing us down based on lowest common denominator quality measures that really aren't measuring quality. It's homogenizing us through standardized expectations that don't capture the uniqueness of every healthcare situation. It's force-feeding us EHRs that become these huge elephants in the room. And this is from somebody who never actually had paper records. I have had EHRs for the 10 years I've been in practice. And even I can say it's an elephant in the room. it should be technology that serves us in the background, not this big thing in front of us. And it's commoditizing us, right? And that's dehumanizing to both us and our patients. None of us feels seen. We're not feeling Eros, and we're not loving. We're not practicing love in medicine. Imagine, for example, what would happen if we decided that checking boxes in an EHR template, cookbook style, wasn't cultivating Eros in medicine. I mean, healthcare would crucify and resurrect itself from the inside out. Say an EHR could capture love in medicine accurately if it would allow us to be seen and for the patient to be seen. We'd adopt it in a heartbeat, right? We're not troglodytes. We're not backwards people who don't accept technology, who want nothing to do with it. We're actually the ones who adopt new technologies and innovations in medicine faster than just about everybody else, almost too fast in my opinion. I heard somewhere that Senator Al Franken was talking about why doctors don't just get with the program. They don't just adopt all these things, that we're just acting like old dogs who can't learn new tricks, right? Some of us are like that. Okay, my dad, probably one of them. But Franken just doesn't get it. That's not the reason that doctors as a whole hate the EHR. It's because we are increasingly unseen in using it. Now, I think most of the audience here would agree that free enterprise is the greatest vehicle we as human beings have created to cultivate love on a mass scale. Free, voluntary, mutual exchange that benefits both parties in the exchange is an act of love. Entrepreneurship is Eros. But others have distorted that message, that it's all about money for doctors, that the existing system is selfish and doesn't care, that we would let grandma die on the streets. Okay, so we need a system that increases access to care so grandma can live, that aims for healthcare for all. Otherwise, you're heartless. I want healthcare for all, too. I want universal healthcare. I am Bernie Sanders. I had that line on my thing before Arthur Brooks said it. Who wants poor grandma to die on the streets? That's ridiculous, right? But access to what? This? Does this give grandma access to something that is worthy of her, that truly improves her quality of life? If doctors are burning out in droves and patients whose premiums are going up because of a system that will break down because of all this access, or who wait in long lines because of healthcare rationing, if they're getting ripped off, if there's no love in medicine anymore, is this universal healthcare? I mean, just look at that phrase again, universal healthcare. It's bogus. It's not universal with rationing. It's not aimed at lasting health with hollow stopgaps for the sick. And it's not care. The whole phrase becomes nonsensical. This is non-universal sick herding. Okay, it's not universal healthcare. And if you have an increasing shortage of doctors because doctor parents are telling their kids that, there's no love in medicine anymore because Eros is gone, okay, then what? What happens to all those well-intentioned attempts to increase access to care? Now you have a bigger crisis, right? And now you bring in nurse practitioners, extenders, Walmart clinics, but you're just going to replace burned out doctors with burned out other people. You did nothing to rebirth Eros. That's not my idea of healthcare for all. This non-universal sick herding is morally wrong. So what do? We recognize that the real crisis in medicine doesn't involve quality measures, standardization of practices, ICD-10 codes, CPT codes, pay-per-performance sticks, big data crunching, MAPRA, MIPS, PQRS. It's love, stupid! That to me is what it's about. How do we rebirth and cultivate love in medicine? How do we rebirth the erotic? Okay, well, the first is to recognize that we are each precious, unique individuals who are part of a community. We're whole parts. To cultivate Eros is to cultivate that. It's to recognize the precious uniqueness of every encounter between a doctor and a patient. And it's to recognize that we are part of a community. We're a network. The patient-doctor relationship is the sacred foundation of all of medicine. And that patient-doctor relationship is situated in an interconnected system. Arthur C. Brooks wrote in The Conservative Heart about the crucial distinction between complicated and complex. He's spot on this. Okay, he says complicated is something that is hard to understand, but once you get it, you can build something and fix it, and you can replicate it over and over again. He uses the example of a jet engine. Okay, it's hard to understand, but once you figure out how to do it, you can make jet engines all day long. Okay, complex is something that is initially easier to understand, but it can never actually be fixed once and for all, even if you throw more money and brain power at it. Why? Because the relationships between all the variables are too uncertain. Okay, he says this is why the war on poverty failed, because its architects thought poverty is like a jet engine. Okay, so what's the patient-doctor relationship? Is it complicated or is it complex? What do you think? I think it's complex. I don't think it's complicated, to use Arthur Brooks's terminology. It's complex. It's not something you can pour tax dollars into with meaningful use programs. It's not something you can just fix. Healthcare is cultivated. Okay, it won't be solved, in my opinion, by a group of policy wonks. These are imperfect, fallible human relationships that are built on trust. Trust is what drives patient-doctor relationships. And what's on the inside of that trust? Love. Love's on the inside of that trust. And what's on the inside of love? Eros. That energy is on the inside of love. That's what the government should be incentivizing. It should be studying why physicians are burning out left and right. Like Frederic Bastiat, it should see the unseen, right? It should acknowledge the unintended consequences of its perhaps well-intentioned endeavors to promote, to achieve universal health care. It should promote entrepreneurship in medicine. It should allow people to use their tax dollars to get care that truly charts a new course for their health, not just give them access to drugs, procedures, surgeries, and useless annual physicals. Do you know what costs trillions of dollars? That. You know what can save trillions of dollars? Not acute care medicine, but what I call root care medicine. Now, don't get me wrong. I mean, I trained at the Texas Medical Center. The Texas Medical Center is second to none in the training of acute care medicine. I know how to do acute care medicine. And you've heard people like Dr. Armstrong saving lives through acute care. So acute care is a valuable part of what we do. Okay, but I also know the limits of acute care medicine with regard to chronic conditions. Helping a patient get to the root of their health problems, not just masking their symptoms with drugs or surgery. And you know what root care medicine is based on? It's based on trust. Trust between two unique individuals and their family. Love is on the inside of that trust. Imagine what would happen if physicians decided that Medicaid and Medicare weren't effectively cultivating Eros in medicine for the poor and the elderly. That they, or any other insurance for that matter, weren't altering the deep trajectory of someone's health. Have you guys heard of Dean Ornish? Anyone? Dean Ornish is a doctor who created a program years ago in the Bay Area that reverses atherosclerotic cardiovascular disease. Reverses it. Okay, so how does he do it? He combines an intense nutritional protocol with meditation and yoga practices and a community of support where people get together and they love each other. Okay, and he has a venue to do this, okay? So nutrition, mindset, community, and an environment. It's a 4-quadrant affair that he does. And he's got Eros alive and well in his program, right? So whether Medicare should cover his program or not is an argument for a different day. But why did it take 16 years for Medicare to cover that program? 16 years. Okay, and Medicare approves in like a quarter of that time bariatric surgery. Bariatric surgery is not hitting all 4 quadrants. Obesity is a 4-quadrant affair. I mean, you can lose weight by doing bariatric surgery, but are you going to hit mindset? Are you going to hit nutrition per se? Are you going to hit community? Are you going to hit an environment? I don't think so. According to a study by Fidelity Investments, a married couple in their 60s will use an average of $220,000 in medical expenses before they die. $220,000. Are you kidding me? Nobody should go bankrupt because of medical expenses. That's inhumane. We should all have a safety net. Okay, but that safety net would be much cheaper and more financially sound, which Arthur Brooks describes in The Conservative Art, If we were good stewards and we provided catastrophic coverage for those with the inability to pay, let tax-free dollars be used by people to pursue root care, what I call root care, and then let human beings freely care for each other. The healthcare cost curve doesn't bend down by increasing access to this nonsense. It bends down by changing health behaviors, right? And health behaviors change when you show people a big enough why. There's a TED Talk that's become famous. A lot of you may have already seen it. It's by Simon Sinek. And it's really all about why. Dr. Armstrong knows about it. See, the biggest crisis in medicine, in my opinion, is not how or what, it's why. Eros is in that question, why? Never forget that. Why do our patients get inspired by us? The great leader is tapped into the why. Okay, the how and the what are secondary. Why are we doing what we're doing in medicine? What's it all about? What's it all about to you? Because that's what you'll remember. You'll remember your kinship with your patients. You won't remember so much what you did for them or how you did it. Okay, and they'll remember that of you. They'll forgive you for mistakes in the how and the what. We had a conversation about that very thing last night in terms of screw-ups. We all do screw-ups in the how and the what. They'll forgive you for that. They'll even thank you afterward for that. They will not forgive you if you screw up the why. They will not. Okay, what's the number one cause of medical lawsuits? Lack of communication. Right? That's the why. Empathy, love, communication. That's what patients want to see. And nothing we ever do in the how or the what, even though it can be perfect, will ever cover up for a lack of why. Right? And a lawyer will rake us over the coals for that, even if we're perfect in the how and the what. Maybe we can defend ourselves successfully in a suit and win that, but where's the Eros in that ordeal? It dehumanizes us even more. So now I'm entering what Gaffney calls the third stage of love. Okay, he calls it sweetness. Okay, Eros, for me, is coming back online again. I have decided to leave the third-party payment system. I've gone insurance network free as of today because it's not really serving what I want to do. Okay, I want to practice a form of medicine that's not just about biology, drugs, and procedures. It's also about community, the social, the interiors, right? I want time to spend with patients. I want to help them discover the root causes of their illness through addressing nutrition, mindset, stress, and what is of ultimate concern. That's making me feel alive again, right? I want to write and talk to groups like yours. I want to honor the sacredness of the patient-doctor relationship. I want transparency of prices in medicine. I want to be seen for the value of the service and the guidance and the shepherding that I provide in multiple ways, not just by scoping. Okay, it's almost sacrilegious, I think, for a gastroenterologist to say this, but that's where I am. I want to be seen in my practice of medicine in my totality, right? And I want to see patients with those eyes, and patients will value me by seeing them with those eyes. And if it's not that I'm against third parties. If third parties recognize what I want to do in the future, I will return. See, every one of you has to find out your why. What sparks Eros in you? What, frankly, do you find erotic? That's what you need to figure out in your medical careers. Whatever it is that encourages you to give your unique gift, the gift that only you can give in this universe. Right? Now, I was going to say, remember that scene in the movie Rudy? And my wife said, buddy, you're older than you think. Rudy came out before these guys were even born. So Rudy is a true story of a football player named Rudy Rudiger. It's a Disney movie, and I'm a sucker for Disney movies. So it's a story of a football player who actually is not a football player. He wasn't big enough to be a football player, fast enough or strong enough, but he had a lifelong dream to play football for Notre Dame, right? So he somehow managed to get on the team. He worked his butt off. He never got to play because he wasn't really good enough to be a football player. But on the final game of his senior season, he was able to go in. And I'll just play you a short. Yeah.
Rudy!
You ready, champ?
I've been ready for this my whole life.
Then you take us out on the field.
Rudy, come on, man. Come on, Rudy. Come on now. All right, let's go.
So I'll stop that for the sake of time. But I always remember that scene. Like, it's one of my favorite scenes, right? Are you ready, champ? I've been ready for this my whole life. Then you take us out on the field. Right? That's electric to me. That's erotic to me. Right? The patients need you to find out this. What have you been ready for your whole life? If you don't know what your why right now, that's okay. But if you don't care about your why, if you think other things are more important than your why, or if you're apathetic to your why, or if you're content with letting third parties decide what your why is, then get out. Just get out now, right? Because that's not what your patients deserve. They deserve something more than that. They need you to take them out onto the field, right? And if you don't take them out onto the field, they are at a loss, and so are you, because you're going to burn out. That's what's compassionate. That is what's morally right. That's what caring for the poor, the disadvantaged, and the unhealthy looks like. A system doesn't do this. Erotic people in an accommodating system do this. Find your why. Don't worry so much about the how and the what. Find what makes you erotic. Love, outrageously love in your practice of medicine. So that's my dad, and that's my son, Ashwin, and he's 13 weeks old as of yesterday. So, thank you. So how did he get here? Okay, it wasn't easy. My wife had 3 miscarriages. And during this time, we went to OB-GYNs, and all her tests were normal. Now, do you think the fertility specialists that we went to were interested in at all about the fact that she had an autoimmune condition called Hashimoto's thyroiditis, which you may have learned about already, and how that might be influencing the pregnancy? No. They wanted to just talk about in vitro fertilization, right? So they just wanted to jump straight to that. Now, I'm not blaming them. They were well-intentioned. Actually, that's a lie, right? The way IVF works is everybody puts their rates on a registry. They all have to put it on this thing, and everybody gets to look up what the success rates are. So naturally, people go to whoever has the best success rates. So why weren't our fertility specialists the least bit interested in even being curious about the fact that maybe, just maybe, this autoimmune condition can influence the success rate of pregnancy? And if they are interested in that and they raise their rates, they're just going to go up on that registry, and it'll help their bottom line, because IVF in most states is a cash pay operation, right? That boggled my mind. And yet, they wanted to put her on Lovenox, which is a blood thinner, because one test was barely positive for a protein S deficiency, which I repeated 3 more times, and it was completely normal, right? And they insisted, oh, that one test is there, let's put you on Lovenox. Now, if you just do some basic research on this test, you will find that if she, my wife, had truly had this to be a real positive, okay, she would be one of 5 people in the world to have this particular phenotype. 5 people, right? So no talk about pretest probability, no talk about positive predictive value, no talk about clinical meaningfulness. They just want to put her on Lovenox. Okay, to me, this is absurd. It's absurd, right? So what did we do? So we made some commitments. We addressed some nutritional issues. We looked to see how we could maybe dial down the autoimmune inflammatory response. And we kept at it, and she did acupuncture, and in a month and a half, she was pregnant, and here he is. Right? What would happen if this is how we practiced all the time. See, this is personal for me. Eros is deeply personal, right? So that's really my biggest issue that I've had with Obamacare. It doesn't get the fact that it's all very deeply personal. This personally affects hundreds of thousands of doctors and millions of patients, including my wife. It's not just policy think. It's not just wonky stuff. No, so virtually everybody agreed that our healthcare system had serious flaws, but they focused on the how and the what, and they didn't focus on the why. And they did not realize what the real crisis is, which is the lack, I believe, the exile of Eros from medicine. Time? Okay, good.